So let's move on to thyroid imaging. Starting with the neck ultrasound. Neck ultrasonography is the preferred modality for routine radiographic evaluation of the thyroid gland, as it offers the most accurate visualization of thyroid nodular disease and allows for the concomitant ability to perform percutaneous fine needle aspiration (FNA) biopsy of thyroid lesions. Neck ultrasound provides information about overall thyroid size and vascularity, presence and risk stratifications of thyroid nodules, and presence of suspicious cervical lymphadenopathy. In addition, it can be used to localize parathyroid disease. Advantages of ultrasound include the fact that it is non-invasive and portable for the clinic, and it is not associated with radiation exposure. One potential disadvantage of neck ultrasound is that the study quality is highly dependent on having a skilled operator. This issue is amplified by practice and institution-specific variations on what specialties perform ultrasound, since radiologists, surgeons, pathologists, and medical endocrinologists all may be trained to perform the procedure. Efforts to standardize the quality of neck ultrasound have included common ultrasound training and credentialing pathways regardless of specialty, as well as standardized templates for neck ultrasound reporting. The normal sonographic appearance of the thyroid is homogeneously echogenic with uniform ecotexture. Pathologic findings on thyroid ultrasound are described in the appropriate sections below. The next is the nuclear scintigraphy. Thyroid scintigraphy is performed using either technetium-99m per technetate or a radio-labeled iodine nuclide, typically 123I or 131I. Depending on the specific study, the tracer can be administered intravenously, orally, or via inhalation, and images are obtained anywhere from 30 minutes for IV injection to 24 hours for oral administration afterwards. The thyroid normally displays symmetric uptake bilaterally. Nodular disease can be classified into whether there is an increased focal uptake, the so-called hot nodule, or not, the cold nodule. Classically, hot nodules in the setting of hyperthyroidism are thought to be benign toxic nodules with extremely low risk of malignancy, whereas cold nodules carry a 15% risk of malignancy. Improvements in ultrasonography and cross-sectional imaging over the past few decades have rendered thyroid scintigraphy obsolete in all but a few scenarios. A thyroid optic scan is useful for the differential diagnosis of hyperthyroidism by determining whether increased radiotracer uptake occurs diffusely throughout the gland, as in the case of Graves' disease, or in more discrete hot nodule in cases of solitary toxic adenoma or toxic multinodular goiter. In addition, radio-labeled iodine scans, usually referred to as radioactive iodine (RAI) scans, are commonly performed to assess for and treat persistent or recurrent or metastatic disease in the setting of differentiated thyroid cancer. The next is the cross-sectional imaging. CT or MRI can be useful adjuncts to ultrasound for specific indications, as they can provide precise cross-sectional anatomic assessment of the thyroid gland relative to the other structures in the neck, including the larynx and trachea, esophagus, muscles, and major vascular structures. These modalities are helpful particularly for two scenarios: substernal goiter and advanced thyroid cancer. CT and MRI have improved ability over ultrasound in visualizing the infraclavicular mediastinum. In addition, cross-sectional imaging more readily detects vascular anomalies such as the Lusoria artery that can alert the surgeon to complex anatomic situations, for example, presence of non-recurrent laryngeal nerve, and assist with perioperative planning. Many surgeons prefer CT over MRI due to its greater ease of interpretation, as well as its superiority over MRI in the detection of cervical lymph node metastasis. If ordered, cross-sectional thyroid imaging should evaluate not just the neck but a wide craniocaudal dimension from the skull base to the tracheal bifurcation in order to accurately assess the extent of interthoracic goiter or malignancy. Both CT and MRI can be performed with or without IV contrast, depending on the clinical scenario. For evaluation of substernal goiter, a non-contrast CT or MRI is sufficient. On the other hand, IV contrast is indicated for clinical suspicion of advanced thyroid cancer, such as locally advanced tumors or those with multiple and/or bulky lymph nodes metastasis. Contrast-enhanced images are best for assessing the local invasion into neighboring structures, particularly the aerodigestive tract. On non-contrast CT scan, the thyroid appears homogeneous and mildly hyperattenuating compared to the surrounding muscles, whereas iodinated contrast administration leads to fairly bright diffuse enhancement. On MRI, the thyroid can be mildly hyperintense on both T1 and T2 weighted images, with bright enhancement on gadolinium contrast administration. Incidental thyroid nodules can be found in up to 9% of neck CT or MRI scans. Iodine is generally cleared within 4 to 8 weeks after iodinated contrast administration, which generally does not cause a significant delay in postoperative RAI administration for DTC. Another modality is the positron emission tomography, known as PET. The PET, typically coupled with CT or MRI, is most frequently performed with the administration of fluorodeoxyglucose radiotracer, that is FDG, which is taken up in tissues with elevated metabolism of glucose. The normal thyroid takes up FDG to a similar level as surrounding skeletal skeletal muscle. The role of FDG PET is limited to selected cases of high-risk thyroid cancer, such as for surveillance and staging of RAI refractory DTC. PET is not recommended for the routine evaluation of thyroid disease. However, with greater use of these scans along with other cross-sectional modalities for cancer surveillance purposes, incidental thyroid nodular disease is being detected by PET scans with increasing frequency. Up to 3% of PET scans identify incidental thyroid nodules. PET-positive nodules are generally associated with an elevated risk of malignancy, up to 35% in average. But this fact does not supersede the need for a standard evaluation with neck ultrasound and FNA biopsy prior to consideration of surgical management.